everyone for joining us. My name is Kelly du Plessis. It is not Elna. I've had to log in on Elna's Zoom link, unfortunately, just to be able to host this evening. Thank you so much to everyone for joining us for this, what is going to be an exciting discussion around the possibility of an establishment of a rare disease advisory board within the South African space. Just a little bit of housekeeping, please. We will be opening up the floor to discussion for everybody who is attending at a later stage in the evening. What we're going to be doing first is we're going to be hearing from Professor Chris Hendriksz, who is going to be telling us a little bit of an overview about the needs and the benefits of a rare disease advisory board. And thereafter, we have a couple of speakers who will quickly be giving us a run over of what it would mean to them as an industry. And from there, we will move over to opening up the floor for discussion and really getting into the nitty-gritties of what this could possibly mean for us. So if you have any burning questions that come up whilst the webinar is underway, please make use of the Q&A function, which should be at the bottom. This just enables all of us as panelists to be able to identify the questions and obviously make sure that we ask them and answer them in the discussion platform. And then obviously when we've opened the floor up for everybody to be able to obviously engage and speak, etc., it would be, if you can, please just raise your hand if you have a comment, etc., so that we can just keep it orderly and people aren't speaking over each other. So with that, I'm going to hand over to our very knowledgeable expert, Professor Chris Hendriksz, who joins us from a rare cause. Prof, yes, looking forward to hearing what you're saying. Thank you so much for joining us.
Good afternoon. Let me quickly get the sharing going. There we go. You will give me the moment just to quickly grab the screen. Get that into presentation mode and not end up at the end and start at the beginning. Hopefully you can all see that. So it's my Really, it's my delight to quickly share with you. And I thought I always want to start off with this picture. For those of you who don't know, this is what ChatGPT has told me what the perfect watch would look like. It would be never needed to be wound. It would have all the functions we would need, but absolutely, as you would all know immediately, it would be completely against any progress. And that's my advice to anybody starting to think about an advisory board. Is this watch will weigh about 25 kilograms, and you can immediately see why this is completely useless. So don't wait for perfection, get going. I do have my disclosures, and just that everybody knows. So a Rare Cause is the charitable arm of our family company, AFAMCA, which has been working in low and middle income countries. But what I want to share with you today is a little bit of a bird's eye view. I had the privilege of growing up in South Africa, practicing there, and then moved to the UK of personal circumstances with my old child, just as we were setting up rare disease services in the UK. And one of the things we actually had is we set up this advisory board, and I've highlighted for you here, the Lysosomal Storage Expert Advisory Board. We set up guidelines and all the other things, and basically what it consisted of was a group of clinicians, patient organizations, allied healthcare professionals, that's pharmacy, physio, everybody else, Department of Health, and a public health chair. And what we did is we set up this system. Now, it was a really good model, but I've also worked in multiple low and middle income countries. And I'm going to tell you a little bit more about, if I could redesign, what advice would I give you from what I've learned? Because this organization worked really well, but it had a lot of limitations. The biggest limitation is basically it was centralized. So it meant you pull all your expertise in the middle, and you have a kind of a autocracy where the people in the middle controls everybody and nobody else. Unless you're part of this, you don't have access. Now, that is not particularly good for patients. And I'll tell you a story. In one of the countries I worked, we managed to find enzyme treatment for a patient, and we were very delighted. We started setting it up. And then when we caught up with him 3 months later and asked him, how's it going? He said, could he please stop? And we said, why? He said, well, I work. It takes me 2 days to travel to the center, 1 day in the center, and 2 days to go back. I have no time to work. I don't have an employment anymore. So although it focused a lot on the guidelines and how medically we should be looking at people, and also around the budget, it lost the personal or the human element. And that is the bits that I think we needed. more of when going forward. It did look at some of the individual cases, complex cases, which was a good thing, but it had multiple gaps in the system. And when I think about a rare disease patient, I have this vision in my, let's see. I've got this vision in front of me. And one of the problems we made is that we did not firstly distinguish between what is a rare disease and what is an orphan disease. And a lot of people does not always know the difference. The two are not interchangeable. And in a regulatory context, they are completely different terms. So we just need to be careful when we use them. And that's one of the mistakes we made up early. Firstly, quickly, you know there's about 7,000 rare diseases. You know the 1 in 17. There's inborn errors of metabolism, which is a subgroup, about 1,200 disorders, and then lysosomal storage diseases, which is only 50. So our advisory board only looked after 50 conditions, which for me was completely wrong. The other thing as well is there are multiple common diseases, but there are genetically subgroups which need special therapy. These patients, to develop their treatment because they're such a small subgroup, is incredibly expensive. They are the orphans. So remember, an example is that you can have breast cancer, which is not a rare disease, but you can have a subgroup of a rare mutation, which then makes developing a treatment for that submutation very expensive, and that is an orphan. So it also makes the big distinction to just remember, orphans are all expensive. Rare is not all expensive. Majority of rare has got no treatment and does need a lot of support. So keep that in mind as we start going forward. And I think it's really important when you set up an advisory board, you need to set it up wide, cover the whole range of disorders, and also to cover your orphan conditions, because they share some of the things, although they're not entirely exactly the same. The next thing is just to look at things, and I say to you, please remember, always put the patient in the center, but the patient has linked to so many other elements. That patient with his rare disease has got a family. That rare disease diagnosis impacts the family. It has genetic implications for the wider family. It's got implications for health education, their education, employment, the family as well. But also beyond that, there's also society, and we mustn't forget that. So that patient will have an impact on society. Do we want a clean society with no rare disease patients, or do we really want a society which actually represents the full diversity of everything we have as a human race? There's also the funders, there's multiple treatment options, there's drug developers, regulators, ethics. These all needs to be considered. So when you set up an advisory board, don't look at the medical needs, look at the patient as a universal person inside a family, inside a society, and develop your system around those. So what would I suggest that you do? My suggestion would be that you actually look at what we call the decentralized model with a virtual advisory board. It's a model which we've used in other services which we use in low and middle income countries. And basically what you have is you do pool your expertise in the middle, but it's virtual. And that middle virtual advisory board can then do multiple things for you. Firstly, if you've got a patient you're unsure about the diagnosis, they can support the local clinician sorting it out. If the patient organization comes back and said, actually, you've suggested the treatment, but this patient lives in an area, there's no electricity, so it's impossible. We need to be able to answer and give them advice and say, actually, the ideal therapy is this, but in this patient's circumstances, maybe this is the better option. It needs to be able to review complex cases or those which are unusual, but it needs to be there. It needs to allow remote supervision. So somebody wants to treat a patient for the first time with a rare disease 400 miles away from your virtual center. Virtual is everywhere, which means we can be there with them, support them, help them, and give them the skills. The reason I'm saying that is what we've learned is you kind of find pockets of rare disease patients. You find that most rare disease patients in most parts of the world end up living within about 25 kilometers of their center. But what we do is we don't want everybody to move to the centers. So we want to have multiple small little centers, the kind of hub and spoke model where you've got a nice center, but multiple scattered outside spokes, which can give all the services and also they can give input. This board should help in the training and developing future things. And ultimately, the main thing is it should develop guidelines. But the guidelines should actually include all of these elements and not be just pure medical guidelines. So a guideline should include something like what is the inclusion criteria, what is the exclusion, but also what is the stopping criteria? When do we stop a treatment? How do we involve the patient organization to give us a social history and a better implication of the patient, that we know actually what we're suggesting is appropriate? And in certain cultures where I've worked, it's not appropriate for patients to be treated at home. They have to be treated centrally. But how practical is it? And these are the kind of things that this board should be able to answer. And I hope that is just to give you a little bit of a sense. But what's most important for me is that the model should be able to give impartial advice and support any one of these functions, and uses all the best available evidence at that point. And evidence is lacking in rare diseases, but common sense should not be. So we can make common sense decisions and say, at the moment, there's no evidence, but how do we capture it? How do we improve it? And you do need to review all the time as things change. So it's really important to keep that in mind. So I know I'm a little bit out of my comfort zone with all of the intricacies of the South African healthcare system. But what I say to people is that if you're going to start, just have goals and be committed. So make sure if you kick off, say, let's have the first steering committee meeting soon. Develop your governance and constitution. Don't develop them and then start, because then you're going to be waiting for the perfect situation. Start and develop as you go along. Get your steering committee going. Set up different ad hoc groups if needed. Set the timescales and keep to them. Make sure all your contributors is keep in the loop. Make sure you get some draft guidelines going for the key disorders or punch points at the moment. They don't need to be perfect. They may be completely inappropriate, but then use them as a tool for everybody to comment. Why are they inappropriate in this healthcare system? How can we change them to be appropriate, that we don't exclude patients who really deserve treatment? And really, ultimately, continue to strive to be inclusive. Try and get as many of the different elements of healthcare to be involved, but do make sure it stays independent from influence from any group, which is not to be putting the patient in the middle. And that's my little bit of advice that I would give Stolta. And I'm going to stick my neck out, and this is kind of what I thought. So if you're going to be looking at, what I would suggest is maybe you need a small virtual advisory board in the center with a representative from maybe laboratories, Department of Health, medical schemes, SAMA, rare disease patient organizations. You can add to the list. I'm sure that's what the discussion is tonight. Who should be the core people? And then you can have ad hoc subcommittees. Somebody gets caught in with, why do we treat a specific condition, or rare versus orphan? Or how does the central people interact with the provincial health authorities? Or do we need to bring external advisors in? Do we need to bring expertise from another country in? And I've got a lot of contacts from different countries who can bring this expertise and just say, this is what we've done, this is what worked, and this is what failed. And not to tell you what to do, but to learn. I think it's Einstein that said, and that's what I'm going to leave you with, don't expect different answers if you always ask the same questions. So let's start asking different questions and put our patients in the center. And that's as little as I want to say at this early introduction. And I'm going to jump out of here and rather give the floor back to everyone else.
Thank you so much, Prof. Short and sweet and to the point. And I think certainly you've captured a good overview of who should be included. And I think we've done pretty well in terms of trying to find someone from each of those areas to put forward their views. So with that, I am going to, just a reminder, if you're wanting to submit questions, please do so via the Q&A. So with that, I'm going to hand over to Prof. Vorster. I always call Prof. Hendriksz and Prof. Vorster my Chris squared, because they're the two people I go to the most for help and advice. I'm going to hand over to Prof. Vorster, who will be speaking from Northwest University, who will hopefully give us some insights as to how an advisory board would have benefit from a diagnostics perspective.
Okay, Kelly, just a second. I'm just trying to get my video on. There we
There
go.
we go.
Thank you for the introduction. Can you see my screen?
Yes, we can.
Yes, we can.
So yes, like you said, I'm from Northwest University, but for the purposes of tonight's meeting, I would like to see myself just as an independent laboratory person, because I think the advisory board needs to be independent, and that's actually something that Chris Hendriksz just mentioned. So I'm just going to talk very briefly about what I think the role of the laboratory would be in an advisory board. And I do believe that the advisory board should be primarily clinician driven, because that's where the hard decision needs to be made. But I think the laboratory has quite a large role to play. And so that's what I'm just going to briefly show to you. This is not exhaustive, but I think it will give you some idea of how the laboratory can function. So what I try to show you is that, you know, there's an interaction between the Rare Disease Advisory Board and the laboratory, or I must rather call this laboratories, because the rare diseases services are fairly scattered in South Africa, and one of the challenges would be to bring all of the laboratories on the same platform to provide the necessary information. So from a laboratory side, you know, we can provide you with disease prevalence and disease statistics that's required for decision making. Although we don't see the patients ourselves, we're often in discussion with clinicians, and very often we know what the common presentations are. So many of the rare diseases can present in different ways in different stages of life. But typically, one particular presentation would be more frequent, depending on the genetic background, of course, as well. But usually, we have this kind of information, and we can share that with the Rare Disease Advisory Board. Of course, we also know what is available in terms of diagnostics and monitoring purposes. So it doesn't help if you prioritize something, but we can't actually diagnose it. And we also often discover certain trends. You know, so for example, a couple of years ago, when we started to test for lysosomal storage disorders, I didn't really think that we're going to find much. And now MPS II is actually the condition that we diagnose the most frequently. So we can report on these trends, and that can help the advisory board to make certain decisions. We're often very involved in education, also of clinicians. And then I think, you know, what we're not doing at the moment, but what we should do is the post-diagnosis information dissemination. Make sure that the patient links into the Rare Diseases Advisory Board, the patient organizations, registries, and so on. So I think that's a service that we could offer. Then on the other hand, we also need some help from the advisory board. So, you know, very often when a clinician make a diagnosis, the laboratory is the first point of contact. And sometimes, particularly if these are acute presentations, we're often required to advise on treatment. And what would be very helpful there is South African guidelines on the more common diseases that we can advise appropriately. Then also, if you report out your testing needs based on information that you have, then we can react to that. I think we will play a central role in repositories and rare diseases biobank. And then also, if there are particular research requests, I think it's easier to administer or to organize particular research projects using the laboratory as a base to do that from. Just to take into account, I think metabolic laboratories have been associated with rare diseases in South Africa, but there are many other laboratories that we require. So there's immunity, metal-related disorders, genetic disorders, and then others. And then also to consider also the future, where proteomics and metabolomics are starting to play a larger and larger role in the diagnosis of rare disease patients. And all of this is going to some extent, I think, not dictate, but there's going to be an interaction between what laboratories can offer and what the structure of the Rare Diseases Advisory Board should look like. So I think the discussions there would be very important in future in setting up the advisory board. So that's about what I wanted to share with you. It's, like I said, it's not exhaustive, but I think it should give you an idea of what I think the role of the laboratory or the laboratories should be in such a Rare Diseases Advisory Board. Thank you very much.
Thank you so much, Prof. Very, very interesting stuff. Yes, I think that there's a lot that goes into the laboratory side of things that we, you know, from a practicality perspective, often forget. And certainly from our close relationship, we have a keen understanding on the level of commitment that's required from you guys, particularly as a laboratory, in terms of advising and providing input when clinicians are really at a loss. So I think that provides a really good segue to now move over to Professor Jacques Snyman, who is going to be making a presentation representing the medical fraternity from a clinician's perspective, speaking on behalf of SAMA. So, Prof. Jacques, I can't see you yet, but hopefully you will come into view shortly. Maybe if you can just start speaking and we'll see if it switches over. Thanks.
Thanks, Kelly. I put my camera on. It's not much to look at, but I mean, it's on. You can see it.
It's working now. It's working now. Thank you.
Right. I haven't made a slide for this purpose. So when I put my SAMA hat on, remember SAMA's motto is healthcare and promoting healthcare. So it's advancing the healthcare of the nation. So this fits in exactly into that coordination aspect where we represent clinicians and we represent the clinicians with the patient as the center. With other words, how do we get what we do to the patient? So it's for me, it's a coordination function around the patient. It's a coordination function around the clinician. It's looking at it in a multidisciplinary team approach, not necessarily only from the doctor, and that is to promote access to care. Both of Chris's has already pointed out. You often get the diagnosis, or you want a diagnosis, but the patient needs the support. So SAMA sees itself as a coordinator in the middle of this in order to make sure that it's aligned and doctors can get access on a single platform to information, with other words, going to your advisory board and panel, and also support where it comes to, for instance, the ethics part within this, and also perhaps assist with the health technology assessment. So that is where SAMA see it as a player, as a coordinator for access within the greater medical fraternity. It would also then link into how do we, how would you say, channel funding into this particular environment. And when I call it funding specifically because it's not necessarily always funded by a medical scheme, not in full. And it's also looking at patients without medical scheme funding. It's how do you coordinate donor funding and access into this particular realm that we're stuck with. So it's making sure that the doctors then can access your platform, as Chris has explained, with other words, that coordinating, creating the awareness, making sure that it fulfills all the ethical criteria, with other words, equity of access, and then obviously the support of the clinician in accessing what he or she thinks the patient requires most in this for the care of their patient. The doctor is the advocate of the patient, but often because of the difficulties within the funding environment, it's almost impossible for them to really benefit a patient in the way they want to benefit a particular patient. And this is where SAMA sees SAMA self as that vehicle in order to create the awareness, but also the route of access with the lowest resistance, and also interacting, therefore, with the different regulatory environments that plays a role in the space. And the regulatory environment, if you look at the Council of Medical Schemes, that's only one player. You've got the SAPRA, the Health Products Authority, and obviously a Health Professions Council to play a coordinating function within that space, making sure the healthcare of the patient is at the forefront. So I'm going to stop at that just to make sure to outline where SAMA sees itself as a role player and as a coordinator.
Thank you so much, Prof. I think some pertinent points as well with regards to the role clinicians need to play. And I think certainly the current environment takes clinicians away from caring for patients because they spend so much time administrating and having to get involved in the nitty-gritties of funding and finance, etc. So it would be really, I think it would be really, really helpful for there to be an independent body that it could kind of serve, you know, in that space, allowing clinicians to go back to what they're doing best, and that is treating and caring for patients. I'm going to now hand over to Fakir, who is going to be giving an overview from a pharmaceutical perspective, coming from IPASA, the Innovative Pharmaceutical Association of South Africa. So Fakir heads up the Patient Access Working Group. And Fakir, I'm going to hand over to you.
Thank you, Kelly. I just lost connection.
I can see you and I can hear you.
Okay, perfect. Kelly, is my slides available, or do I have to present them?
If you can share them your side, if you need me to pull them up, I can.
All right, perfect. I'll pull them. Okay, while I'm pulling my slides up, sorry, I didn't know that I had pulled up. But while I'm pulling my slides up, just about IPASA. IPASA was formed in 2013 with a desire for a credible, respected organization to engage with stakeholders in the public and private sectors and representing research-based international pharmaceutical companies who make many of these rare disease medicines. And we are dedicated to innovative medicines. We committed to a healthier South Africa. And we're pioneering research and development also into rare diseases. So I'm going to share now, just a sec. Go.
Perfect. Thank you. They're coming through.
Wonderful. Okay, disclaimer is you'll see Roche on the top side. So that's my day job. My night job is working for IPASA. We were asked to look at the gaps in rare disease management. So Kelly, I followed the orders. When we look at what are the gaps, there's limited access to treatments. There's lack of approved therapies for many rare diseases. We know that there's only about 10 to 20% of rare diseases that currently have treatments. If we look at the policies, rare disease policies around the world, only about 20% of the world's countries have a rare disease policy. There's also big delays in bringing the innovative treatments to market, not just market globally, but market locally as well. Locally, we have the challenge of our visible price, which is the single exit price. And because of that visibility, sometimes pharmaceutical companies don't bring the medicines to this market because of the risk it has of referencing in other markets. And we only represent about 1% of the global market. Reimbursement challenges in South Africa. There's inadequate funding for rare diseases. There's no clear criteria for how rare diseases get funded. Our PMBs are outdated, and rare diseases are not incorporated in the current PMB algorithms, except for maybe hemophilia and a few others. There's complicated reimbursement processes that discourage innovation. We know there's about 70 medical aids with different reimbursement guidelines. Very few of them fund treatments for rare diseases. From a regulatory point of view, I mentioned the visible pricing, and we lack clear mechanisms for alternative reimbursement models. We have seen recently that some companies are not even registering the medicines in South Africa, but bringing it in on Section 21, thereby bypassing the visible pricing regulations. So we've seen this example with Trikafta for Vertex. Another gap is awareness and education. There's insufficient awareness even among healthcare professionals about rare diseases. We need some sort of comprehensive education on early diagnosis and treatment options. The way I see the role of an advisory board in addressing these gaps is threefold. So there has to be collaboration. We need policy development, but like Prof said, policy development not just relating to one area, but comprehensive policy development and research and development. We need to encourage dialogue between all the different stakeholders, like we do at the Rare Disease Access Initiative, and share best practices and innovative solutions to overcome barriers from other markets around the world. On the policy side, we need to provide insights and recommendations to shape policies that support research and market access of rare diseases. And we need to really advocate, and this is big, for streamlined reimbursement processes. We struggle in the private sector with the Council for Medical Schemes and in the public sector with the National Department of Health to try and get traction for them to consider rare diseases, the support for rare diseases. Fostering research and development. We need to identify priority areas for research funding and partnerships and promote initiatives that drive clinical trial access in South Africa and patient registries. Also compassionate use programs. So key considerations. This is again my view. We need broad stakeholder representation with diverse voices, the most important of them being patients, healthcare professionals, and industry leaders. We need representations of different rare diseases as well to address specific needs. I believe we need to be focused on outcomes and patient-centric outcomes. And as a group, I believe they need to establish metrics to evaluate the effectiveness of these interventions that we create. And there has to be transparent communication, clear communication channels, and building trust amongst participants to ensure accountability in decision-making. What I'd like to suggest is that this be independent. I think there was an initiative like this before where independence was lacking. So that's a big, one of the big criteria or considerations we need to take into account. Yeah, thank you very much.
Thank you so much, Fakir. Your ability to follow the brief means I have terrified you in previous discussions. I've now got you in line. Thank you so very much. I'm now going to hand over to Mr. Charlton Murove, who's from Board of Healthcare Funders. So I think we've had a nice flow. We've gone from understanding the global concepts to the diagnostic through to the healthcare professional, obviously understanding the implementation in terms of medication and access to treatments. And now we're moving to the funding and regulatory space. So Charlton, if I can hand over to you. Charlton is he's with the Board of Healthcare Funders. For those who are not aware, are one of the administrators, and Charlton can give you an idea of how many schemes they cover, because I don't actually know offhand, but it is a couple. Charlton, thanks.
Thank you, Kelly. Thank you for having me. May you please allow me to share my screen?
I think it's Fakir. Fakir, you have to stop sharing to allow Charlton to take over, if you don't mind, please.
Let me try.
Sorry, I didn't know that. I just need to see how to do this. I'm not used to Zoom. It still gives me an option only to share. How do I unshare?
You should be able to click stop sharing.
1 second. Sorry about this, guys. Stop share. There we go.
There we go. Thank you very, very much.
The joys of Google Meets at our company. Bye.
Thank you.
Okay, you can confirm if you can see my screen.
I can only see you now. Nothing's coming through yet from your side.
Oh. Okay, it says I'm sharing. Let me try again.
Yeah, now something's coming through. Perfect, thank you.
Okay. Yeah, yeah, I will try to stick to time. So, okay, so who is the BHF? We are a representative body for health funders, mostly consisting of medical schemes, administrators, and what guides what we do is trying to create a health system that is affordable and accessible to the health citizen. It's deliberate to use the term health citizen in that we want to see our environment growing. So whatever we do as medical schemes should be such that we can have more people coming in. And when we do policy advisory, we are always considerate of the broader healthcare system. What we find is a bit of a challenge in terms of funding for rare diseases and orphan diseases as well, is the environment is quite fragmented. If one was confronted with such a condition, what they need to do will depend on which scheme they are on and on which benefit option they are on. In some instances, patients have to go through an ex gratia process, which creates a lot of uncertainty. This uncertainty impacts not only the patients, but I think even pharmaceuticals who are trying to bring in new products into the market. Often what they share with us, it's quite expensive to be meeting many different schemes and doing various motivations for the different medicines and so on. So the fragmented approach obviously makes it quite difficult. And then from the funder perspective, trying to fund for these conditions is a bit of a challenge. I think the idea of PMVs has been mentioned, and they also create an unfair situation in which there is a prescribed benefit, yet the cost for the benefit is not prescribed. And then the rare conditions often have huge financial impacts on the medical schemes. So a lot of care has to be exercised in terms of how schemes look at this. And I think generally everywhere else, healthcare is known to be quite expensive and affordable. And I think this context is important to appreciate from a funder perspective. So in terms of what we have done as the BHF for looking at a solution to address some of these concerns, we are working on establishing a cell captive arrangement, which is in short an insurance company that will be owned by the medical schemes. They will set the rules. And what this does is it helps smooth the claims experience of schemes in terms of funding these conditions. So we would like to minimize the financial burden on schemes as much as possible and bring it at a level where it becomes an industry approach rather than an individual funder approach. We are quite excited about the prospect of having a advisory board. I'm speaking from the point of view of the BHF in this project. What we do see happening is the cell captive arrangement will rely heavily on the expertise that will be sitting in the clinical advisory board. We do hope and we believe that it will be independent and it will be able to provide us with the clinical expertise that is needed. I think initially what we need is funding guidelines, which the cell captive is going to use. Our hope is that the schemes will also adopt the same funding guidelines. That will help in terms of bringing standardized approach to funding some of these conditions. I think how it will work from a beneficiary perspective, it will still be exactly the same. The clinicians, it will be quite similar, though they will have to start interacting with the clinical advisory board and providing necessary information. So this is how we see things working out once the advisory board has been established. Obviously for the funders as well, having that one central place for knowledge will help. They will know where to go for the expertise, bearing in mind that it is not easily accessible. So the desired endpoint really is, we would like to, first of all, ease the financial burden for schemes, and then try and standardize the approach to funding these high cost interventions as much as possible. And at some point, bring the cost down of these interventions. And hopefully will increase access to these expensive medicines. This is my last slide. Thank you.
Thank you so much, Charlton. I look forward to the day when the cell captive arrangement is in full swing. Last but not least, from our panelist perspective, is Dr. Samantha Iyaloo from Council for Medical Schemes, who I think will be giving us an overview on, from a regulatory perspective, how an advisory board could possibly add value. So, Dr. Sam, if I can hand over to you.
Thank you so much, Kelly. Good evening, everyone. Just trying to share.
Your slides are there.
All right, I'm just putting it in presentation mode. There we go. Can you see it? Can you hear me?
Perfect.
All right, thank you. So thank you for the introduction. It's my privilege to partake in this important discussion. I'm going to go right into the presentation and giving a policy and regulatory perspective from the medical schemes to regulator point of view. So firstly, just change this. So firstly, to address the current gaps in the reimbursement and the care of rare diseases, we have to discuss the changing landscape of health needs and the challenges the industry faces. There are increasing costs of healthcare, the changing burden of disease, an aging private member base with medical schemes not attracting enough younger members to cross-subsidize the old and sickly. We face an uncertain environment with changing priorities as we aim for universal health coverage via the NHI. And the medical schemes environment is fraught with fraud, waste, and abuse, ultimately all contributing to increasing health costs. So the center picture depicts the principles of equity versus distributive justice. We all understand the need for equity in healthcare and that all beneficiaries should be entitled, everyone should be entitled to healthcare based on their needs. However, we are operating in an environment with limited resources and constraints, and we often face difficult decisions. So the ideal of health for all is in stark contrast to the health for the majority versus health for some that we are faced with. The last diagram demonstrates that with any intervention that we aim to put forward, we first need to ensure that it is equitable, that it is effective, and that it is sustainable. So regarding the regulatory environment and the establishment of a Rare Diseases Advisory Board, the Medical Schemes Act provides provisions for a list of chronic diseases and diagnosis treatment pairs as part of the prescribed minimum benefits. So according to the Medical Schemes Act, these PMBs need to be reviewed every 2 years. A previous review was done and submitted to the minister, who advised that the PMBs were too hospice-centric and advised the CMS to focus on primary health care. So the focus of the current PMB review over the last few years has been on establishing and costing a primary healthcare package, which ensures alignment between national health policy priorities and the CMS. So a full review of the PMBs is still to be undertaken once a primary healthcare package has been incorporated into the PMBs. You can appreciate that affordability will be a great concern if we would like to add, the PHC component to the PMBs, and thus a full review of the PMBs will need to be undertaken and services prioritized. Work on the current PMBs is ongoing with the PMB definition guideline project, which defines entitlements for PMBs, incorporating some elements of HTA in determining what should be considered as PMB level of care. So we use standard treatment guidelines, we use local and international guidelines, clinical evidence and cost effectiveness analyses to develop these guidelines. It is a multi-stakeholder driven process with clinical advisory committees. There is definitely an area for expansion to define entitlements of some of the prioritized rare diseases. So research and data are always important, and certainly the CMS can assist with some data related to PMB rare diseases and provide information on out-of-pocket expenditure, claims ratios, utilization, and others. Other areas where gaps can be bridged is the reviewing of managed care organization treatment protocols, ensuring that they comply with benefit definition guidelines we have published, and also looking at thematic issues around complaints and adjudications on PMB entitlements and benefits. We also do member education, where we publish CMS scripts, which provides guidance to members on their PMB conditions. So lastly, the regulatory and policy considerations for a newly established Rare Diseases Advisory Board are to look at how rare disease screening can be incorporated into primary healthcare. Obviously, the data and research will need to justify the incorporation of rare disease screening. An advisory board can look at the alternatives for medical schemes to fund high-cost rare diseases, such as reinsurance, and Charlton took us through that. We also need to look at the establishment of centers of excellence for the management of rare diseases, which could be formed from public-private partnerships incorporating economies of scale, purchasing, and public incentives for treatments and rare diseases. So all of these considerations require an advisory board to develop a structured, multi-stakeholder, targeted approach to the management of rare diseases in terms of coordination, policy, and data. I think that's it from me. Thank you.
Thank you so much, Sam. Much appreciated. Really nice to see CMS referencing the Rare Disease Access Initiative outputs. I think it makes us proud to know that our documents are being read. So I think just in terms of from a patient perspective, so certainly I think we've seen in our engagement with many countries where advisory boards exist, that they certainly fulfill a massive role in terms of providing some form of equitable care. I think that the barriers that we find from a patient community in the South African space at the moment is, and this is across both sectors, it's not specific to one, but with regards to knowledge, so obviously rare disease awareness is low. It's not, we don't have hundreds of clinical experts to rely on. And the people that are often making decisions around access and funding, funding and policy, etc., are very often the least knowledgeable in the room. And what that results in is patients don't have the certainty that the decision that has been reached following an appropriate knowledge process, which I think is very, very frustrating for us. Certainly from a transparency perspective, this is another issue, and I think that this is something that an advisory board will assist us in achieving, is having transparency. So when be it a funding decision, a treatment decision is made, often they are contrary or, not necessarily what the patient would have desired. So a alternative treatment method might have been put forward to what the patient has read on Google would be a good option, or you might have a decline coming through from your funder or the hospital, etc. And patients want transparency. We want to understand how the decision was made, why it was made, and these are sometimes difficult conversations to have because it hasn't necessarily gone our way. However, that transparency really helps us to understand what can often be a difficult outcome for us. And at the moment, we don't have much transparency. We are simply provided with either letters of decline, stating that we can't have something because it's deemed to be unaffordable. There isn't enough data, there isn't enough evidence to support treating with that, etc. And often we are the only person that is providing us with any form of communication in that regard is coming from the funder, and it doesn't come across as an unbiased view, obviously because the funder has a role to play as well in terms of managed healthcare. So transparency for us, I think, is critical, and I'm certain an advisory board would be able to assist in giving patients the certainty that decisions have been made with good knowledge, and that there is transparency in what process has been followed, and how that decision was made. And then lastly, in terms of equitable access. So again, you know, as our patient community, we do understand that sometimes we're not able to get everything that we want, but we want to be able to start somewhere. But I think it's incredibly frustrating to when you are a patient accessing a particular service within a particular facility and you can't get it, but 7 kilometers down the road, there is another hospital that is able to provide it. Or within the medical schemes environment where you have medical schemes playing up against one another, even within the PMB space, whereby you have, you know, a patient that can get something on one medical scheme and another medical scheme has a completely different interpretation. That makes it really, really difficult for us to accept, because if there is good data, good evidence, etc., you've got that accountability and transparency, and you know that the decision has been made by people who are knowledgeable about what is being placed before them, it'll be much easier to accept the outcome of that decision. So getting equitable access, we understand that the pot is limited in terms of financial reimbursement. We understand that the knowledge base is lacking, and we all do everything we can as a collective to address those issues. But patients want equitable access just as much as any other stakeholder in the room. And then lastly, obviously, involvement. Patients need to feel that they're heard. They do provide lay expertise. No one can give you more insight into the lived experience than what a patient can. And that experience is ultimately what we're trying to improve. We're not just trying to improve symptoms. You're trying to improve the patient's overall quality of life. And as a result of that, you know, certainly patient participation within the advisory board is absolutely necessary, because we bring elements of knowledge, of understanding the condition that you wouldn't necessarily know unless you've been there and lived with it. So that is it from the patient perspective. We are now going to open up for questions, discussion, comments. So looking forward to that. I see some hands have already gone up, which is super exciting. So if everyone can just give me 1 sec to find my feet here, because, right, it is showing me only, there we go. I can see the hands. They're coming finally. Okay, so the first hand that has gone up is coming from Dominica. Dominica, I've opened it up for you to be able to talk. And please just, if you have a question that you would like someone in particular in the panel to address, please just notify us of that accordingly.
Yeah, thank you very much. Thank you very much, Kelly. I don't have a specific questions. Congratulations for organizing this beautiful, interesting webinar. I do underline that I remember the first speaker underlined that it's interesting to include in the advisory board also international experts. And I do agree with this proposal, because I think it's interesting and important to share experience and knowledge from other countries. So that's it. I would like just to underline this. Congratulations again.
Thank you very, very much. And yes, certainly, I think particularly in the rare disease space, reliance on knowledge from abroad is absolutely critical, because we don't necessarily always see enough of it. So thanks very much for raising that point. The next hand that went up was Rick Dedeker.
Okay, thank you very much for allowing me to take part in this very interesting discussion. Maybe I should declare my interest first, and my interest is directly to the patients themselves and not funding as such. My perspective is from an academic hospital, from Red Cross Children's Hospital, where I worked as a clinical geneticist and a pediatric cardiologist. And we dealt with many, many, many rare diseases quite routinely. And the focus on funding and how much the private funders are going to make or not is a bit disturbing. I think we should focus on the patients and the best way to give clinical best treatment and best expertise to the patients. And I would suggest that should be done through the academic institutions, and that the access to academic, clinical, and genetic experts is made as easy as possible to those patients and to the parents of those patients. I'm a pediatrician, so I have a very child-focused view of healthcare. And because having a rare disease is clearly a very, very costly problem that can go throughout your whole life. And we should protect those patients from basically bankruptcy. And for the funders to be mostly spoken about in this seminar about how they're going to deal with getting funds and so on is putting the cart before the horse. We should look at the patient first and see what the needs of those rare patients are and where they can get the best treatment they can possibly get, which I would suggest would be at the academic hospitals in the country and the outreach clinics that each one of those academic hospitals do to the regional hospitals in all centers in South Africa. Thank you very much for making a bit of a adversarial comment maybe, but I think it needs to be said.
No, absolutely. I think, and I'll open it up to any of our panelists.
Remember, we are not talking to the stock exchange. We're talking to the health care of children, mostly. Okay, I'm a bit irritated. I know.
I 100% agree with you in the academic facilities.
Yeah, yes. Please send the children where they need to go, not talk about the money where they needs to go.
Yeah. So
yes.
I think we can open it up for comment, because it certainly is our view. Patients are patients first.
Yes.
However, even within the academic facilities are hamstrung by what they are able to offer.
Not at all. Sorry, I'm not at all. Hamstrung is not an issue. Okay, I worked at State Hospital for all of my academic life, and we've never had a hamstrung problem. We have problems sometimes with bed space and so on, but that's not what we're talking about with these rare diseases. They don't need acute care. They need a diagnosis, and they need care that can take at home. Their parents need to be educated. Their teachers, their society needs to be educated. How do you deal with these children that live with rare diseases? We at Red Cross Hospital deal with rare diseases constantly, and it's got nothing to do with hamstrung funding.
I'm going to open it up for comment if anyone has anything to say in response.
Remember, it's rare, so the funding doesn't have to be massive.
May I step in? My name is Yuri Machenko.
Yes, Yuri, sure.
First of all, thank you so much for inviting me for these very interesting discussions. I'm based in Switzerland. Even though I was pretty deeply exposed to South Africa, being employed by a company and focus on ultra-rare disease, what I also realized and provide my comments here, it's very, very important to understand how patient advocacy networking has been established in your country, because it's very, very important. Sometimes it's quite crucial when families can provide feedback, can facilitate, can support from one side you as experts, and from other sides to deal with authorities. Different groups from different people, and based on my own experience in Europe, in Latin America, she became more and more. And what I realize here is all at the moment, there is still a need to develop such networking collaboration with families. Country is pretty big, and it's also quite important to see such communication. Perhaps what I would also advise, based on my own experience in other regions, in other countries, to arrange a roundtable with authorities, experts, and the families to understand their needs and to find a own view how to proceed, move forward together. So again, it also depends on the willingness of all sides. I also understand sometimes nowadays it's probably easy to do not only face-to-face events, but rather than virtual. But families are very, very important and crucial. And referring to the previous speaker, I totally agree. In rare and ultra-rare disease, it's very, very important to identify patient as early as possible. It's important to understand if there is screening programs around the country, what kind of biomarkers could be utilized, are they expensive or not expensive, can be covered by the hospital or the insurance company or by the authorities, or to some extent companies facilitate, but they're limited in terms of a specific indication. I would also rather to think of to establish, like, just give example, doesn't mean that it's reflect the area of rare ultra disease, newborn screening, which could be also help to understand and as early as possible diagnose those patients. Unfortunately, the outcome and quality of life and the duration of survival of those patients who are identified being on the screening programs limited, and in most cases such diseases associated with genetic background, genetic mutations, and they could be devastating. Thank you very much.
Thank you very, very much. The next hand that went up was Dr. Andre Dupnard.
Good evening, everyone, and thank you for giving me the opportunity to be part of this panel. Just by means of an introduction, I'm an adult physician with a couple of different interests, particularly cardiology, nephrology, and I am currently the Senior Clinical Fellow in Critical Care and Transplant Medicine at the University of Edinburgh and the Royal Infirmary of Edinburgh in the UK. I am usually based in Cape Town, South Africa. I'd like to just bring in an adult perspective. Rare diseases has been a sort of passion interest of mine for some time, and I'd like to reflect on Prof. De Decker's statements that he made earlier, not particularly about the funding, but the access of care, and I think the clinical care of the patients is an important aspect that I think we need to, that would be a big role of the advisory board, is to sort of direct a pathway for the patients. And I'm hearing a couple of good comments there in the chats about genetic diagnosis, the role of the laboratory we've heard of. But I think a challenge that I've seen in both public and private sector is, where do we send our patients and who looks after them with a rare disease? Who is the actual clinician that will take care of them? As Prof. De Decker mentioned, they have an excellent service for these patients at Red Cross. But again, we also mentioned about the centralization of these patients. That is a bit of a challenge. What happens when one of these patients comes in late at night? And a second part to that is, what happens once the patient turns 18 or goes into adulthood? Granted, the majority of these conditions are present in childhood, but there are some that present later. And I think that would be one of the challenges of the advisory board, is to find a way, how do we sort of hand over care for patients from specialist centers like Red Cross then into adult medicine, and then which physicians will look after them, which doctors are capable of dealing with these sort of rare multi-system diseases. Because again, you can't just, as a patient, probably go to your GP for most minor complaints. You're going to have to go to someone with very specialized knowledge. And in South Africa, there are very few doctors, and depending on what the base metabolic or the base genetic complication is of the genetic diseases, that would then dictate which doctor you would have to go see, or subspecialist you'd have to go see. And I found it quite challenging. I often didn't know who to refer to when you do get a patient with a certain diagnosis, and also who to ask for help. And I think that would be a major role for this advisory board, is providing that clinician assistance and to direct sort of treatment pathways so that there are no barriers for the patients.
Thank you very, very much. Very, very good points raised and taking notes here as you go. The next hand that went up, I think, was Fakir.
Thank you, Kelly. I wanted to answer one of the questions that I saw in the Q&A. Just a sec, I'll put my video on. The question was relating to, the person said, as an advocate, I'd like to understand what deters pharmaceutical companies to register medicines in South Africa. Is it only the SEP issue, and who regulates the process? So there's a long answer to this and there's a short one. So I'm going to try and be as brief as possible. There are many factors that deter companies from registering medicines in South Africa, and single exit price is only one of the issues. And some other considerations are the regulatory environment. SAHPRA is responsible for registering the medicines in South Africa. The process can be lengthy, it can be complex, which may discourage companies from pursuing it. There are certain costs associated with maintaining drugs being registered. And if it's a small molecule, these costs, and the smaller companies, these costs can become prohibitive. Another one is market size and profitability. So the South African market size relative to the developed market, it may not be attractive for all pharmaceutical companies, particularly for niche or low demand medicines. With regard to pricing, although the SEP system is there and can limit profitability, pharmaceutical companies are concerned about the impact of price controls on their revenue and the ability to recoup R&D costs, and also international reference pricing on that SEP. There's also IP issues, intellectual property. Sometimes there's concerns about patent protection. In South Africa, we have very strong patent advocates, and that may deter some of the international companies as well. Competition and market access, another one that could probably affect it. And so in summary, it's SEP, yes, is one of the things. The other things is also, other concerns are also around reimbursement of these medicines. So often in South Africa, we're confined by the PMBs. As Samantha mentioned, they haven't been updated since 2001. We have benefits review committees that provide input into these committees, but rare disease is not even on the agenda. So I think part of the advisory board would be to get that rare disease on the agenda of the policymakers. And number two is, if we don't, because I don't see current funding mechanisms as being appropriate for rare diseases, maybe we need to explore others.
Thank you very, very
We
much.
need to explore others, like a rare disease fund, like the cell captive model that Charlton presented. But as a country, we owe it to our citizens to do something.
Thanks very, very much, Fakir. Much appreciated. Njabulo?
Thank you, Kelly. Just a brief introduction of myself. I am a clinical geneticist. I'm a geneticist. I'm based at NHLS, the National Health Laboratory Service, which we support largely our public health institutions, and we do testing. And my initial comment is to say, when it comes to rare diseases advisory board, I do believe that the genetics community, from genetic counselors to clinical geneticists, and yes, laboratory genetics experts, needs to be involved, because we are the group that is really at the cold front of dealing with rare diseases in South Africa. And yes, we do have two major centers in the country, as far as I'm aware, Cape Town being one, and Johannesburg. That manages, but that is just about it. So one of the speakers here spoke about access, and so there's many other provinces across the country that have difficulty of access. So there's many other areas that do not have access. So that's one area that I think the advisory board should be working on in terms of getting services to different parts of the country. Secondly, and I saw some of the comments in the Q&As here about diagnosis. Yes, it is a fact that even from NHLS perspective and our what we could offer, there's still limited testing available, and without testing and without diagnosing, there's no treatment to offer, and that becomes one of the stumbling blocks in helping patients living with rare diseases to have a diagnosis and a fair treatment or care in their lives, even before we even get to the point of having the treatments available. So I think that for me, that will be to say, genetics and genetic groups will really need to be part of this. And professionally, these groups are well organized. In my knowledge, there is a Southern African Society of Human Genetics that I think will participate effectively, especially when it comes to developing guidelines for testing and for treatment. They can play a major role, and of course coordinating with all other experts within the healthcare setting. So it is my feeling that it should be that as representative as possible, that so that the people who deal with rare diseases on a day-to-day basis are also heard, and their frustrations and their coordination is also noted from the advisory board perspective. Thank you.
Thank you very much. Palosho?
Thanks, Kelly, for the very informative session, and thank you to all our speakers. It's just a suggestion, Kelly. If we decide to do the rare disease ad board again, would it be worthwhile for us to bring in a patient who suffers from a rare disease? And the reason I say this is we've dealt with a gentleman who was diagnosed with a rare disease at quite a young age, and he's been fighting his whole life to get access to treatment. He eventually got access to treatment. I've listened to some of his radio and television interviews. He speaks quite well and very knowledgeable on his particular disease. So maybe something for us to consider if we decide to do this again is to bring in a patient so we can get perspective from someone who actually suffers from a rare disease.
Thank you very much, Palosho. Prof. Hendriksz?
Thank you. There's lots of comment, and I will try not to. First I would just want to make a comment to Rick and saying that I fully agree with you. By the sound of you, you may be my kind of age. The biggest challenge we have is that we don't have a lot of young docs coming through interested in rare disease. So this is the ideal opportunity for the advisory board to encourage local doctors to become the experts rather than everything needing to go out. And let's get the focus back on patients. I'm all with you there. Running into what Andre has said as well on, I know it's not ideal, but internationally we've worked a lot on transition already, and that was my comment. Let's not go for perfection. You may want to look at some of the models which we've started already. They are imperfect, but have something to work with, and then try and see how do we build a service which is appropriate for the country. That would be my next suggestion. And then the last one is just some question that was in the chat I wanted to touch on, is that somebody asked, but how are we going to capture all these diseases? There are so many diseases. My suggestion would be, having been in the field, is that the person who asked the question has most probably got the answer. So I think what the advisory board should most probably do is get a standard template saying, this is the disorder, this is the issues, this is what I think is the solution, this is the research potential for the future, and yes, the literature. And then we could use that as a starting point and then develop from there. That way you have multiple entry points and things happening immediately, rather than waiting for a slow process where disorders one by one come into your system.
Thank you very, very much, Prof. Helen?
Hi, everybody. It's Helen Malherbe. I'm wearing two hats currently, and
oh no. Oh, sorry. I tried to allow Helen to put her camera on, and I don't know what I've done, but I think I've it's come up with an
I'm back.
Yeah, thanks. You can put your camera on. Sorry.
Thanks, Kelly. Just to let you know, I wear two hats. I'm a consultant to rare diseases 2 days a week, Rare Diseases South Africa. And I'm also a director of Rare Diseases South Africa, heading up research and epidemiology. Then my other hat is as an academic researcher based at the Center for Human Metabolomics with Chris and Ilse and the team. And that's in an extraordinary capacity, just to provide me with an academic home for publications. So my whole focus is basically developing an evidence base for advocacy work, so we could really leverage and press for improved genetic services as a collective, focusing on them as a building block each time. I just have a couple of comments to add with regards to research, and I do apologize, I only joined after it had started due to unforeseen circumstances, but I just want to make a few comments that in building that evidence base to underpin our advocacy activities, there's a couple of things that need to be done, and I really see the role of this ad board helping to make that happen. And one of them is just to consolidate all the research that is ongoing in South Africa and to make the right connections internationally, because there is so much work that's going on. And the problem that we have, as always, is the ivory towers. The left hand doesn't know what the right hand is doing, and we really need to consolidate and prevent that duplication of effort and so on. We've taken a few steps at Rare Diseases South Africa to do that and trying to build up a research hub, but I think we need to have a rethink on it and how to do it more collaboratively. And then my second comment, and with regards to that, I think it speaks to the policy, my second comment, in that we have all these policies and so on, and some of it has been touched on tonight, but obviously there is poor implementation, fragmented implementation. And part of the problem is we don't have detailed information on the cost of this care, of the different interventions, whether it be diagnostic or prevention through relooking and re-monitoring or continue to monitoring folate fortification, for example, and other primary, secondary, and tertiary preventative methods. So I think a part of that is to really develop that health economic base and start doing some analysis and cost effectiveness studies to actually see, for example, newborn screening and basics that are in place in high income countries that we still are very far behind, and we're starting to be very far behind on the continent as well, behind countries such as Ghana and Nigeria that are way ahead of us now, and we've actually gone a little bit backwards. And then my other point, and my final point, relates to capacity. And Njabulo, a few speakers ahead of me, was speaking to the lack of services that we have around the country. There's a paper that's just come out now that shows that we are only functioning, we only have 10% of the medical geneticists and genetic counselors that we need in the country. As a result, those services are limited to a few provinces. The private sector, this is state services I'm talking about, the private sector is saturated. We've lost 8 of our newly qualified genetic counselors to the UK in the last 2 years, and because there are simply no posts. So this is going to be, I see a major role of the ad board to help build up that capacity and for the post allocation, while we are facing the revised or the renewed moratorium in terms of no, and austerity measures in terms of no new posts allocated. We're going to have to think cleverly, I think, about this and consider returning that role of the genetic nurse that we had previously in South Africa. We had a network across the country that could then filter and take the burden off of the genetic counselors, who can take off the burden of the medical geneticists. And so they only need to see the complex cases. And also, I think we need to bring in the role of other clinicians, perhaps, and to build up the connectivity there, because I don't foresee us having enough capacity. But I'll finish my points there. And we also have the issue someone alluded to, is that many of our doctors now, including our medical geneticists, are retiring in South Africa. We're losing a number before the end of this year and several more within the next 4 years. So things are going to get worse before they get better. Thank you.
Thank you very much, Helen. Sarita?
Hi, thanks. Thanks, Kelly. I just actually want to commend Prof. De Decker as well on his comments. So I think something that we very, very often overlook in this country when we talk about rare disease in these kind of platforms and things like that is the fact that, you know, that 80% of our population is in the public sector. 80% of our state patients, our rare disease patients are in the private sector. And honestly, as a medical scientist working in an academic center in the state diagnostic service, I know from serious experience that we have a wealth of experience, of phenomenal experience in our academic centers. We have clinicians who honestly deal with rare disease patients on a daily basis and know so much more than the rest of the country about dealing with them and about treating them and about how best to go about it. Because maybe also because we work in strained environments and because we work with less resources, we have clinicians who are absolutely phenomenal at finding ways of treating patients that are innovative and you know, we have ways of finding ways of diagnosing patients. And we have very dedicated people in the state academic hospitals, in the clinical setting, in the diagnostic settings. We may have very little genetic services, but the ones that we have work incredibly hard and are incredibly dedicated to rare disease in South Africa. So I think we cannot talk about policies and advisory boards without having our academic centers be at the center of these discussions. So yeah, that's just my view.
Thank you very, very much. I couldn't agree with you more. I mean, we've always maintained that our patients in the public sector get much better care coordination than that in the private sector. And I mean, you guys will know how often we refer patients for, you know, genetic counseling and stuff because that hasn't been made available to them in the private sector. It's not something, you know, for whatever reason, private sector doesn't make the referral. And so 100% agree on the clinical expertise that lie in the academic centers, which is why I think we are so supporters of having, and we've participated as much as we have in the centers of excellence work that we have been doing within the Rare Disease Access Initiative, etc. Because the academic skills, and I agree with you on the approach is a lot more pragmatic in a resource constrained environment. So, you know, it just works because it has to. And that's fantastic. I think that I've lost track of hands. I see one more. It's Rita.
Yeah, good evening, guys. Kelly, thank you very much for organizing this. So I'm the Patient Support Manager and Advocacy for South African CF Association. And I think one thing that I could, you know, just comment is that I think it is high time that the patients come back into helping writing the story for South Africa. I think, unfortunately, sometimes we lose a little bit of the reality of what our patients are really struggling with. And I think that should be the starting point. A second comment that I would like to implore us to really look at us, from the advisory board is how can we absolutely make sure that we don't get the split between the private and public sector, so that really when we come in and we suggest a couple of things that, we make sure that everybody has access. And I think the hot topic in our community is Trikafta and how it came in and how it came, sort of accessible. But it created a huge disparity in our community. And we've got so many patients who deserves access. And we just trumping up with a lot of political things, making it fairly impossible for us to get state access. So I think the advisory board really has a space. And I do agree that we need to put the patients in the middle. And I think part of this advisory board, a lot of the views and the comments should be from our patients themselves, and really to ensure that we do not, open up the disparity even worse and further between public and state. Thank you very much.
Thank you very, very much, Rita. Last hand that I see is up is Noluthando. Nolu?
Thank you so much, Kelly. Thank you for hosting this amazing, discussion. I'm coming from the funder side, but I think it's been quite interesting to just listen in on some of the comments that have been made. And I think, when you think about an advisory board, I think it's a great initiative to think about if everything else is in place. And I think in South Africa, we still have a long way to go in terms of just creating a functional structure. I think the previous speaker spoke about, how do we pool the resources so that, there isn't this disparity that currently exists where, some patients, depending on which sector they are in, they may not have the same access. And I think in the private sector, what has been happening over the past maybe few years has been a bit of a maybe heavier focus on the high cost treatments in rare disease. And I think we lose focus of the broader sense of rare diseases, where there are some rare diseases that don't cost much, but those patients still have very difficult journeys because of late diagnosis and other issues. So I think there is a requirement, honestly, to focus on centers of excellence where there's pooled resources. The training aspects that were discussed, will apply in a center of excellence. Development of guidelines, research. It really gives the patients much more because there'll be that focus. And in terms of funding, then it's much easier to have a model that is structured around centers of excellence in terms of funding. And I think all the various funders, whether private or public, could then pool their resources to afford those members access to care. And I think the high cost nature of some of the treatments is not something that's unique to South Africa, and affordability constraints are experienced even by other, well-off countries, if we think about it. So I think there is that aspect, but I think there's a broader aspect around how we create a structure that works for rare diseases, how we pool our resources and create efficiencies. And then in the long term, also, think about how we then cover for the much more high cost treatments. So yeah, I think it's been very interesting to hear, some feedback from the public sector in terms of how they are addressing these. And I think it just reminded us that not every rare disease is requiring high cost treatments.
Thank you very much, Dr. Nolu. The last hand that I see has gone up is Charlton. And Charlton, I'll hand over to you.
Thank you. I think I just want to ride on what Noluthando said. And one of the things that is important is to realize that we have one healthcare system. And when you have patients, they still need care. I don't think it's always fair to try and classify between private and public in terms of we want to perpetuate the disparities and so on. I think our idea of participating and being part of the advisory board is having one alignment. And I think the more we speak to each other, the more we'll find that alignment. What I would like to caution is sometimes we don't know what we don't know. And it's always important to have an open mind and hear the other view and find solutions. I think when Prof. Hendriksz started speaking, he said we cannot start from a point of perfection, but we have to start somewhere. So I would encourage that we are all open to the process of trying to work together to solve the problem, despite where one stakeholder sits. Yeah, thank you.
Thank you very much. I'm now going to hand over to Prof. Hendriksz for him to just give us some closing thoughts. And while I do that, I'm going to launch a poll with two very, very simple questions, if the audience can please answer. I do see that there was quite an imperative comment that I think also should be shared, and this was with regards to, it was Ms. Kath McGaw, who stated, as a pediatric dietitian with the sole focus on special needs, I feel strongly we also need to bring providers to task on the cost of nutritional products that are often life-saving for patients. And I think that this is of particular importance to the conditions where the dietary intervention is really all that is available to the patient to provide them with, that is the treatment intervention. So certainly, I think something worth taking into consideration. So, Prof. Hendriksz, if I can hand over to you, and if everyone can, please just participate in the poll when it comes up. Thank you very much.
No, I just want to say to everybody, thank you for your input, and it's been really enlightening to hear all the different views. And I would like to stress what's been said all along. Patients needs to be in the center of whatever we do, but also I think we need to start somewhere. And my suggestion would be, let's see how soon we can start. Pull resources, knowledge, everything we have together and start working together. Let's build a team that wins and start working and trying to make things better for our patients, because arguing around it or having all the hurdles being brought up doesn't solve anything. It's easier to start and then be aware of the imperfections and then move forward. So I would strongly encourage everybody to seriously consider this. And part of the reason why I was getting involved in this is that some of you may not know, but actually I'm retired. I don't get paid for doing this. This is just my lifetime passion, because I had to leave my country, South Africa, because there was a lack of knowledge to diagnose my child. And I don't want other families to go through it. So let's get the knowledge and the expertise local and find the solutions, not the problems. And I wish you all a good evening.
Thank you very, very much, Prof, as always. I just wanted to quickly share the results. So the first question that came through, and unfortunately, I think that this has only gone through to attendees. It hasn't come up for panelists. I might be incorrect, though. Do you think a rare disease advisory board is needed? And there's an overwhelming response. 100% have responded that it absolutely is. And to the question, would you be willing to participate as a member of an advisory board? 59% have said yes, and 38% have said that they would require more information. Only one participant citing no. So I think that, we have certainly established that there is an overwhelming need, but most importantly, there's an overwhelming willingness to get this done. And I think collectively, we all just need to work towards next steps. Yeah, sorry, I see that it has come up saying that it didn't go through to panelists. Apologies for that. So with time in mind, I just would like to say thank you so much to everyone for participating. A big thanks to the team specifically at Northwest University for assisting us with providing us with the platform, as well as Prof. Hendriksz for always giving us his time, and as well as all of our panelists who have come forward and voiced their opinions and given us some food for thought. as a collective community, you know, as patients, I think we are deserving of having a good quality advisory board in place to be able to guide not only in terms of patient care, but also in terms of, you know, policy development, in terms of interaction, in terms of understanding the needs, pushing for improved service delivery and all of those things. So I'm hoping that we can take next steps to actually get this off the ground. Thank you very much to everyone for attending. If anyone has any other further closing comments, you're more than welcome to pop us an email. But yes, thank you for your time, and we certainly do appreciate it. Thank you so much. Have a good evening, everyone.